Now we will move into the fourth session, which is common problems in general practice. And I would like to introduce Dr. Anmar. He will be the moderator for this session.
Hi. Hi, everyone. Ani Anmar al-Witri. It's an honor to present for this session. I'd like to present our next speaker, Dr. Hyder Ridha, a specialist for ENT. He provides specialist care for both children and adults, including surgical procedures and hearing services. He mainly diagnoses treatment of disorders related to ear, nose and throat, as well as head and neck surgery. Hey.
He's a neurosurgeon, and to my knowledge, he's the only Iraqi neurosurgeon.
There is another one in Brisbane.
In Brisbane, sorry, in Brisbane. Yes, yes. Thank you very much.
This is the So I'm going to talk about, thank you, about common ENT conditions. Thank you for the invite, Dr. Ahmed, and for the organizing committee. So it's going to be practical for you. First, what instruments you need? You actually need to have an alligator forceps. You need to have a headlight, and these days you can have headlights with loops. You can buy it like for $150 on Temu or on eBay. Quite good. It gives you good optics. Also, it's worthwhile seeing the mirror cell pack, which is the one in the middle below. You can buy it as, it's like a matchstick, small matchstick. You put it in the ear as a wick, and you get the drops to go on the top of it. It's going to soak the drops all the way inside the ear, and it can be quite helpful with otitis externa. After 2 days, most of the times it falls by itself when the swelling and the edema disappears. The name is Mirror Cell Pop Wicks, and the company that does it is called Medtronic. Normal tympanic membrane, so we start with the normal anatomy. Victor had a B pointer?
Yeah, the green one.
The green one, okay. Here. Okay, so this is the lateral process of the handle of the malleus. The most important landmark, actually, is the lateral process, not the cone of light. Always tilt the otoscope, look at the lateral process, then look above it to the pars flaccida. That's where you don't want to miss a cholesteatoma. This is the actual chorda tympani, and this is the longer process of the incus behind it, behind the handle of the malleus. So the lateral process is your most important landmark. Now, this is tympanoclerosis, normal white patches, tympanoclerosis, white patches on the tympanic membrane. It's a sign of degeneration, previous history of grommet insertion or ear infections, or both. It has no significance. It doesn't affect the hearing. It is just a sign of previous involvement of the tympanic membrane or the middle ear with something. This is exostosis, which we call surfer's ears, very common in coastal Australia. The problem with this is it does not cause hearing loss unless it's causing complete obstruction. It tends to accumulate the wax closer to the tympanic membrane, and the wax cannot migrate out. When somebody is swimming or having a shower, the water will go in and it'll become smelly and rotten, and then it can lead to otitis externa. We tend to have quite high threshold for operating on this because the drilling of this can lead to high frequency hearing loss. So it is not as straightforward to remove it, and it takes ages to heal. It's very painful after the operation because you lose some of the skin and you have bare bone in the ear. So we tend to delay surgery. Now, this is a very important slide. We have on the left, cellulitis, where you see the ear lobule is involved. When in the middle, when it's only the cartilage, then that's perichondritis. The lobule is spared. You need to make that diagnosis because perichondritis is caused by Pseudomonas aeruginosa, and the cellulitis is caused by Staph aureus and Streptococcus. So you have to give the appropriate antibiotics. This is traumatic auricular hematoma. The next slide shows the problem here is the skin and the perichondrium are elevated from the cartilage, and you get a gap with loss of blood supply to a piece of the cartilage. So it's very important when you drain this or when you aspirate it as a general practitioner, and you can do that, it's not a big deal. Stick a needle and take it out, and then you have to put sutures. It's better to use nylon sutures all the way, like a quilting, transfixion sutures, and you put the knot in the back. So you go in, you go from out to in, then back to behind, and put the knot to drape the skin back and restore the blood supply. Insect in the ear, very common. I've seen mosquitoes, bees, lizards in the ear, you know, anything you see, especially in rural Australia. The most important thing here is the insect, usually it grips. It has a grip to the tympanic membrane, so you have to drown it first to release the grip, then you remove it. And then you cover with local antibiotic. Most of the times they would have caused perforation of the tympanic membrane. Usually it heals by itself. This is otitis externa. This is fungal otitis externa, usually caused by Candida or Aspergillus niger. The treatment here, always otitis externa, the treatment is topical. It's more effective. Antibiotics work, give you approximately 1,000 times the concentration in the external ear or in the middle ear compared to oral antibiotic. So 1,000 times more concentration. Therefore, if the ear canal is open like this and you have access to the treatment with ear drops, this is much more effective. So this is otitis externa, fungal otitis externa. Advise the patient to keep the ear waterproof. That's another one with a bit of eczematous otitis externa, so there's a blistering there. And this is diffuse otitis externa. Now, the problem with this is when you put the drops on, it's not going to get in. So that's when you need the pop wick that you can insert it in, or even a ribbon gauze, and then get the patient to put the drops on it. Then patient can pull it out himself in 2 days' time when the swelling disappears, and then he starts putting the drops directly into the ear when it is open. Otherwise, it's not going to get in. You can always give systemic antibiotic if there's constitutional symptoms or there's lymph nodes, or if you think it's quite severe and you can't get to the you can't get the drops in. Now, this is granulation tissue in the ear canal. It is an alarming sign. Granulation tissue is a sign of osteitis or periosteitis. It is a sign of either necrotizing otitis externa or it is a sign of cholesteatoma. Now, the difference, necrotizing otitis externa, is osteomyelitis of the temporal bone. I'll talk about it in the next slide. The treatment is quite long. It's a disease of immune-compromised people or diabetic. The cholesteatoma can happen with immune-competent and healthy people. So, when to suspect necrotizing otitis externa is when you have somebody who has the immune suppression, plus you see granulation tissue. It's caused usually by Pseudomonas aeruginosa or E. coli or Klebsiella. The treatment usually is systemic antibiotics. The way we investigate it usually with CT or MRI, and we usually ask for bone scan with gallium. The gallium scan is important for follow-up later. When the gallium signal stops showing, then it is okay to stop the antibiotic. Usually they need 2 to 3 months of treatment intravenously. So we put a Baxter pump for them and we give it intravenously. And sometimes we have to get them to have hyperbaric oxygen. And in Sydney, there's one place, which is the Prince of Wales Hospital, where you can have the hyperbaric treatment. When to refer ear diseases? When we have the non-resolving otitis, parotid or mastoid lymph nodes, and they are not responding to antibiotic. When you have cellulitis or perichondritis, and you think there is going to be or starting to have a collection. By the way, with the cellulitis or perichondritis, you can always give like Bactroban or something like Fusidine cream. 3 minutes? Temporomandibular joint involvement, and if there is a cranial nerve paralysis. I'll go to the next slide. This is black color tympanic membrane. It's either a trauma of the temporal bone or blood behind the tympanic membrane or high jugular bulb or epistaxis, goes through the eustachian tube. This is the acute otitis media. That's what it looks like. Sorry. That's what it looks like when you have an acute otitis media, bulging, angry-looking tympanic membrane. The other one is probably a beginning of otitis media. This needs antibiotic. The other one doesn't. You can cover the patient and with Nurofen and Panadol, and after 2 days, if there is no response, you can start the antibiotic. This is just a paper that talks about the need to wait before you give antibiotics and what are the criteria. If the patient generally, or if the kid doesn't look very agitated and doesn't look unwell, then you can continue with the medical, with the non-antibiotic treatment. Mastoiditis, I'll show you this slide. It's actually quite good. It's a slide. It shows the relationship of the mastoid to the middle ear. The mastoid cavity is very much like it is like the sinuses compared to the nasal cavity. This is the mastoid cavity, which is continuation of the middle ear. So remember, if there's middle ear infection, the infection can go to the mastoid, and it can work as a reservoir for future infections to come back after you treat the middle ear problem. Cholesteatoma. That's what I was talking about in the attic or in the posterior margin of the tympanic membrane. When you see what looks like wax above the lateral process of the malleus, be alarmed. When it is behind in the external auditory, behind in the tympanic membrane, in the back at the margin, then that could be a cholesteatoma. When you see white shadow behind the tympanic membrane, that could be a cholesteatoma. Now, this is CT scan of the temporal bone. There is opacification here in the middle ear cavity. This could be fluid or cholesteatoma. That's just the route of the spread of the cholesteatoma from the middle ear to the mastoid. The problem with cholesteatoma is it can lead to intracranial complications, and big part of the neurosurgical practice is from ENT, being ears or temporal bone or sinuses. This is the simple suppurative otitis media. You treat it with just simple antibiotic drops. You can give systemic antibiotic, but again, the same principle, 1,000 times concentration and water exposure. My suggestion always for eardrop, ciprofloxacin hydrocortisone or ciprofloxacin by itself. Ciprofloxacin hydrocortisone can sting the ears a bit. So for children, ciprofloxacin by itself. And for fungal infection, you use locacortin Vioform drops. Sofradex and Otocom, you can use it, but the problem is Otocom is very thick. It's like a glue. When you put it in the ear, frequently the patient will come back and tell you the ear is blocked. And this is middle ear fusion and about just putting grommets. One thing to take home is with adults with nasopharyngeal, with adults, middle ear fusion doesn't happen unless there is something in the postnasal space in about maybe 60 or 70% of people. So we always recommend examination of the postnasal space to exclude carcinoma, nasopharyngeal carcinoma. I think that's probably the most we can say. If you get a patient with sudden onset hearing loss, I would recommend starting them on steroid. They usually need MRI. Start on prednisolone, 50 milligrams per day for 10 days, then taper over another 5 days, while you're getting an audiogram and getting an ENT referral, giving the patient referral for ENT. But meanwhile, you have a window of 1 month to start treating the patient with a steroid before the patient will lose that window, and then there will be no improvement and the ear is dead forever. Alarming symptoms in otology: non-resolving ear discharge, chronic temporal headache with discharge, and vertigo. If this is combined with vertigo, then that's quite serious. This is a sign of the intracranial spread of the middle ear, of the disease to the middle ear. Whenever you see granulation tissue inside the middle ear or cranial nerve paralysis, then that's alarming. I think epistaxis, you guys can manage it quite well. With a sinusitis, sometimes you can have orbital or intracranial complications. And when you see something like this is not a sebaceous cyst. This is actually called post-puffy tumor, and this is an osteomyelitis of the frontal bone. This can lead to superior sagittal sinus thrombosis or meningitis or intracranial abscess, so it is a very serious sign. Always send the patient for a CT scan, and you can see the opacification and the melting of the bone. It takes bone scan and gallium scan will make the diagnosis for you, of course, with the CT and the MRI. And this is just traumatic. 3 minutes? Okay, thank you. Thanks for that. Okay. Now, septal hematoma following an injury. It's exactly like the auricular hematoma. The septum has its only blood supply through the perichondrium. And when there is hematoma, the pericardium will be elevated from the cartilage, and you can get cartilage necrosis and then saddle nose or supratip depression, like this girl on the right. And therefore, it has to be drained, and the same thing, you have to redrape the mucosa back. With the nose, it's easier than the ear because you can put bilateral nasal packing to sandwich the mucosa back after you drain it. If you can't drain, just stick a needle and see after, after you put xylocaine in the nose, like xylocaine spray. But it has to be drained, and it has to be draped back. Normally, we put a drain like that one, Penrose drain. Cellulitis. And this is Bell's palsy. I'm sure you can manage it very well. And I just want to show you, this is post-tonsillectomy slough. This is actually not an infection. Frequently it's referred to as an infection. It is not an infection. This is a layer of dried saliva, fibrin, and white cells, and it takes about 10 days to disappear. And it can cause halitosis, it's painful at that time, and it sloughs and goes by itself. Eating normal food, like the food will rub on it and it'll come out. Chewing gum is very good. It'll exercise and move the muscles, prevents stiffness. Overall, after tonsillectomy, you advise the patient to eat and drink, and if they don't eat and drink, the risk of post-tonsillectomy bleed will go up. This is just a retropharyngeal abscess. Mainly those patients will have problem with neck stiffness and they cannot move their neck, and it is in extension position because of the spasm of the pre-spinal muscles and retrovertebral, prevertebral muscles. And anybody who has hoarseness for more than a month has to get an ENT referral to exclude carcinoma. And this is probably, I find, the easiest about stridor, the easiest classification. You have the paraxial type, which goes usually to pediatricians, laryngitis, epiglottitis, and croup, and the other ones are the apyrexial ones, are usually congenital, except the foreign body. The take-home message here is if you have anybody that has sore throat with normal-looking tonsils or with previous tonsillectomy, think of epiglottitis because it progresses within hours. So quick referral to the emergency department if there are no tonsils and it's the pain is very bad with the drooling. Thank you very much.